Are part of the Primary Care Improvement Collaborative, and they form part of our learning system. So the sessions have been developed to support the collaborative and understand how to use QI tools in a primary care setting, particularly in relation to pharmacotherapy and CTAC. So we will share practical applications of QI tools, drawing on our learning from previous programs such as PCAP. Okay, so in a wee second, a poll should launch on your screen, and just if you can rate your knowledge of PDSA, so Plan, Do, Study, Act. I'll just give that a few seconds to come in. Perfect. So a wee bit of a mix between kind of actually 1 and 5. So it will be quite new to some people and a refresher for other people. So just moving on to the overview of it. So the PDSA is really useful when you want to test a change and assess the impact of that change. So there are 4 steps to the PDSA cycle. The first step is plan, and this is when you would create objectives, predict the impact of your change, and plan out how you will actually implement your change. The second step is do, and at this point you're actually implementing the change. So at this stage it's really useful to actually document any problems and capture feedback as you go. The third stage is study. So this is when we would analyze the data. So you would also think back as to how your results now compare to your initial predictions in your planning phase. And then the final phase is act. And at this point, you would decide what you need to do going forward. Will you adopt, adapt, or abandon your change? So you can see that by using this template to document the different phases of implementing a change will ensure that your test has the best chance of working and support your learning. Quite often, if this is all done verbally or mentally without documenting, details can often get lost and you may miss where there's actually really useful learning. It's also a really good tool to share within the team about why and how a change has actually came about. And finally, it's often useful to revisit the PDSA tool when a change hasn't been sustained. It may help you to understand how to restart your improvement activities. So why is the PDSA useful? So it helps us to learn about what will happen if things are done differently. So it supports us to turn ideas into action, support learning, make predictions, develop measures, and reflect on our change. The PDSA is also helpful to help us understand if a change will actually lead to an improvement. So it's very much iterative learning where we would test, scale up, repeat. When we introduce a change, we should always aim to start with a small test of change and then assess what works, what doesn't work. And using this process will minimize the impact of when things don't work out how you would expect them to. And finally, the PDSA supports small scale testing. So as we gain knowledge and confidence in our change, the PDSA cycle supports the scaling up of testing. And I'm just going to pass to my colleague Gareth just now.
Thanks, Neve. Hi, everybody. So what we're going to do now is just going to talk through an example of a PDSA cycle that was done during, as Neve mentioned earlier, learning taken from our PCAP program. So we have on screen an example. I'll do a little bit of background just so hopefully we can get those folk in to talk about this example. So as I say, an example from our primary care access program that we started in 2022 and is kind of folded that kind of work and learning into the collaborative. So those were done as part of the sprints, the 7-week and 8-week sprints that we did with practices, pharmacotherapy teams, other primary care teams, etc. during that time. So this one was focused on that kind of appointment balance. It was definitely a bit of a tricky time coming out of the pandemic because of the way appointments were dealt with, a lot of demand on the day, um, and a different kind of environment and atmosphere that we were coming into. So hopefully we've now got a few of those extra people on the call. So I'll go ahead. The good thing is this is being recorded, so people will be able to access it afterwards. So the aim here was that patients who didn't have an urgent need were added to the on-call list because the wait for routine appointments was too long, and the GPs didn't actually have any dedicated time for managing this on-call list. So the change idea that was planned was to introduce what they called soon appointments, which was appointments who bookable 48 hours in advance if it was felt that the specific issue warranted this. And this was using time that was already allocated that was currently reserved for GPs only to book directly into. There were some questions about that. How many soon appointments needed? Will people accept those appointments? Will these reduce the on-call list? And even a kind of thing about what's the suitability, says down there, tasks agree the guidance for when the soon appointments to be offered to ensure consistency. As you can see there in the prediction, some things that came up when planning with the team. Some patients might refuse those soon appointments. And there could also be an issue when it came to Thursday and Friday, as the possibility of waiting over the weekend might put people off. So tasks were then allocated in terms of breakdown what needs to happen to actually run the test, who all in the team needs to know about it, what you need to prepare, produce to do the thing differently, and set timelines to tasks and allocate them all across the team. So what you can see here is slide 1 of this 2-slide PDSA is all about the planning. The next slide here, we have the do, the study, and the act. One of my reflections from when I worked in primary care was the study and the act often were reduced a little bit, and there was a succession of plan, do, plan, do, plan, do cycles done in rapid succession after each other. It's not necessarily wrong, but the study is so important because it really lets you know how things have gone, whether it actually went with the prediction, whether you did everything correctly and a different result was attained, but also allowing you to build that kind of knowledge base that you have sequentially through some small PDSA cycles test at change. So 4 of the soon appointments were added each day, and the number of patients on the on-call list was counted. Nice and simple. The data was collated and compared. There was an overall reduction in the number of patients on the on-call list, so it did go with that prediction of the overall reduction. There was also reflections from the team. They kind of valued that opportunity to work across the clinical and non-clinical teams and gain a better understanding of the work that each other was doing. So that small scale testing and working with what you might call a willing few as a starting point allows things to happen and builds that base of information that we have to help to address some of those concerns that were raised early on about, whether or not the change would work, or whether people would accept the change, whether change at all was feasible, workable, etc. What they would say was some unanticipated things happened, but working with a kind of frame of mind where you're open to testing allowed those to be looked at and addressed. And you can see here when it comes to the act that the test change also highlight another area where on the day appointments were being used where routine might have been more suitable. So a further change, a further PDSA cycle was done to address this, introduce another change, and again, make that plan, do the actual change, study it and act. Neve mentioned earlier, when you look at it, you have the kind of 3As, the adapt, adopt, and abandon. But there's also a kind of, in some cases, depending how small changes, the other one of expand the change. You might have done it in a very small area, maybe with 1 or 2 people, and then you looked, okay, let's introduce a little bit more to that. So that's just a very quick example of the Plan, Do, Study, Act in a practical setting in primary care. So I can see that the chat buzz is chat box is going, but I think that might be to do with some people trying to access the call. So I'll have a look about any questions from chat. If you do have any questions, please feel to pop it in. For the folk that arrived late, apologies. There will be a recording available for you all to have a look at. I do apologize about the mix-up when it comes to the scheduling. So just have a wee look at the chat box. I think most of it is to do. Yep. Hi Haley, glad you're here. So if there are no questions, we're going to do that kind of classic before and after poll. So the poll should launch on your screens just to see where your knowledge is now after this little session. Just let those results come in. Minimize it on my screen. So that's it for today. We'll be sharing some tools, further learning resources, and of course this recording to everybody that came along. Thank you very much for attending. Apologies again to those of you that may have got the wrong invite. And yeah, thanks very much. And hopefully we'll see you all really soon. Thanks. Bye.